Thank you, everyone, and really grateful to the organizers for inviting me to speak at this meeting. And it's been excellent talks. Well done to Pam for the organization. So I'm just going to be talking about tic disorders today. And just to say that a little bit about myself, I've like it's been introduced. I've worked in neurodevelopmental disorders for over 20 years. I I have an interest in neurological disorders as well. So I work in the field of epilepsy, run outreach clinics as well, and a lot of neuropsychiatric conditions. So I was fortunate to have worked in the Tourette's clinic in Great Ormond Street, where I had a lot of my training. And I also did an MSc in clinical neuropsychiatry, where I did some research on tic disorders in children. And that's been very beneficial in terms of my understanding of this disorder. I'm not sure what's happened in our area in UAE, but there's been an explosion of tic disorders since the pandemic, and we've seen massive explosions. So it'll be interesting to hear whether that's been the same case in the UAE, but we've certainly had that in the UK. So I'm going to go straight to my talk, which is mainly about looking at tics and comorbidities. I'm going to try and make it as practical as possible, because I think one thing I want us to get today is recognizing the children with tic disorders, and also what do we do when we see them, and how to assess them and manage them. So a bit of a talk on comorbidities, which is the essence of what we'll be doing today. So we hope that we'll be able to get this today. I'm just putting a few histories up, and this is practical patients that have come into us, and they come in various ways. So they don't have a specific way in which they get referred. They can come in with different patterns of their history. So JA, as you can see, I think this will be more common with what we see, eye blinking episodes, head jerking. Episodes were occurring more at home than at school, nothing remarkable in the history from birth and developmental history. Parents, when they see children having these movements, are usually very anxious about what could be going on with the child, especially if these things have just happened. And so we should start thinking, if this was an interactive session, we'll be discussing more about what we'll do and what we'll think and how we can manage the child. So the other child is a 12-year-old girl. She presented differently. She didn't start with the tics. She came in with anxiety and obsessive compulsive symptoms, neck twitching, which were quite emphatic. She had all kinds of noises, and it was impacting her at home and at school. And she's coming to the practice, so she was another one who was referred. And this is more of what we are seeing now, is children who did not have any features earlier, suddenly coming with a lot of anxiety, having motor and vocal tics, been worse since the pandemics. I mean, we're getting so many of these. Sometimes we get at least 2 or 3 every week in trying to minimize. We have them coming into A&E sometimes, and we're seeing them presenting, in quite florid situations with some of the children not being able to attend school. And there's been a lot of school absence and school refusals from a lot of them. And there's been confusion as well, in the sense that some of them may appear quite vacant and confused after the episode. So you see this child coming in, and what would you think? How would you manage this child? So many of us would have heard about this French clinician who the syndrome was named after, Gilles de la Tourette. He described about 9 children with similar behaviors and presentations. And he was, they presented, a lot of them presented, those 9 were presented with motor coordination, incoordination, echolalia, and coprolalia. And the conditions were looked at and eventually named Tourette syndrome, But when you look at the literature, there were descriptions of other clinicians, of people who had described other people with similar behavior. So although Gilles de la Tourette had a syndrome named after him, there was actually description of people with similar features. And it was also said that King William III had behaviors that were thought to be due to Tourette syndrome. So there were several important people with these features. So what do we mean by a tic? We might see children with different movements, but what a tic is, it's very, very brief. It's thought to last not more than 2 seconds in most children. It's very brief, it's rapid, it's non-rhythmic. So when we think about epilepsy and we're describing features, when we're parents are describing, we describe that more of a rhythmic pattern when the children are having the jerks. But a tic is usually non-rhythmic and it can be motor or vocal. Sometimes you cannot differentiate it from normal behavior. It might be like the child is doing a normal movement. So sometimes it can go unnoticed and sometimes it can be more emphatic. So tic disorders are actually a spectrum. So if we go into schools, we'll probably pick up a few children with tics, but not every child with tics has the disorder. In order for you to actually meet the criteria for disorder, you need to have more of an impairment happening. So tic disorders are a clinical spectrum, can vary from mild tics to Tourette syndrome. And one of the things that patients come in getting worried about is, does my child have Tourette? Because they think that's when your child has Tourette, then that's severe. One thing that we can always reassure them is that Tourette syndrome is not the severe end of the spectrum. It's just a continuum of that tic spectrum. It just means you have both motor and vocal tics. So you might have Tourette syndrome and present with a much milder presentation than a child who has just motor tics that's more severe. So it's just a continuum of the tic spectrum. So tics can be simple or complex. So simple tics are what we describe as purposeless. The movement does not mean anything. So if they blink their eyes, it's not trying to achieve any function. So you can have different types of tics, and it's one muscle group that gets affected. So you might have facial grimacing, head jerks, shoulder shrugs. It's just one muscle group. But complex motor tics, it seems as if it's a more purposeful movement. It's as if the child is actually planning to do an activity. So you might have the child moving their head, twisting their neck, shrugging their shoulders, as if they're planning to do an activity. It seems as if it's more purposeful. And that's where it has multiple muscle groups involved. Vocal tics are the same. What you have with the vocal tics is you can have an airflow either through the vocal cord, the mouth, or the nose. You can have simple or complex vocal tics. Again, the simple ones are just sounds, and the complex ones, you can have more things like words or syllables or phrases. The common thing is people think if people are using blotting out phrases, and people think that's synonymous with swearing. Actually, it's only 10% or sometimes less of children who with Tourette's that actually have the blotting out of words, but it's not deliberate swearing. And that's the way to differentiate that it's not deliberate swearing that you're getting with the Tourette's. So tics can be primary or secondary. The ones that we're talking a lot more today about is the primary tics. Secondary tics can happen from infections and can happen from substance use, medications, head trauma, but we're focusing more on the primary tics today. So coming to UAE, when I was looking at the talk, I was trying to say, do we have a lot of tics in UAE? How common is it? Any prevalent studies? And the only studies I could find were ones done by Epen and Roberts. And I met Dr. Epen at the Dubai conference last December. She's a psychiatrist. I think she's working in Australia, New Zealand or Australia now. So she did a study with Professor Robertson, and they compared the incidence of Tourette syndrome in patients in Al-Ain and the UK. And what they did find was that the core symptoms of the disorder were the same. So, but you had less impairment being reported in the UAE cohort. And it was thought that, was it due to the fact that people did not really take it seriously, or physicians downplayed the severity, or there was a stigma in parents coming to report it? But they did find that core symptoms were present, but the severity of impairment and comorbidities was less. So just a quick thing about DSM. So DSM-5, which was launched in 2013, changed the nomenclature, basically the same descriptions. So where we used to have transient tic disorders, which lasted for about 6 months, we now, or 6 months, less than a year, we now have it called provisional tic disorder. Now, if you have motor tics that have gone on for longer than 1 year, just motor tics, you call it a persistent motor tic disorder. DSM-4, it used to be chronic. Vocal tics that have gone on for longer than a year is called persistent vocal tic disorder. And what I've said is Tourette syndrome is you have multiple motor tics and vocal tics that have lasted longer than a year. Now, the vocal tics and the motor tics do not have to happen at the same time. And sometimes you can, you don't need both of them happening at the same time, but you should get a record that it's been happening for at least a year. Should start before 18 and should not be attributed to any medical cause or substance use. Epidemiology, when we look at the literature, it depends on which studies you look at. What we find in the studies on Tourette's, on tic disorders, is that it's got lots of mixtures of population. So it's not a homogeneous group. So you might find a wide age range. You might find prevalent studies being done on a more severe cohort in the hospital. So it's very variable. But what we do know is Tourette syndrome varies between 0.5 to 1. And transient tics is more. So when you go into schools, you pick up more children with just tics, which is not bothering them, and you're not worried about them. We know that we have more males than females, and we know that tic disorders are highly heritable conditions, and we do see a lot of them in families, and that's why we ask for family history. It's very highly concordant in monozygotic twins, both Tourette's and chronic tics. And like we said, it's very highly heritable. We've already talked about who gets tics. We do know that we have, a certain population who might, so children with neurodevelopmental disorders are noted to have a lot more tics. And this is what I was talking about in the cultural differences in how people perceive the distress and impairment from tics. We do need more research on children with tics from the from UAE and other continents, because we don't have a lot of prevalent studies in this group. This is Dr. Tara Murphy. She's a TS specialist in Gosh, and she went to Uganda, and it was the same thing. So she went there for a sabbatical, and she also commented on the fact that she wasn't seeing the kind of population that she was seeing here, but she was seeing the children, but some were misdiagnosed. And I think this is one of the things that we want to prevent, especially if they're not seen by a specialist. So what happens in the brain in tics? I'll just quickly go through this. We know that, what we do know is that the abnormality is in the corticostriatal, it's a long thalamocortical network, and I'll just show a picture of that. And if we just think about it, that the upper part of the brain modulates the movements of what's coming down from below. So your midbrain area has, it's generating movements, but your brain, your top part of your brain, your cortex, fine-tunes those movements. If there's any disruption or irregularities in those pathways, you will get tics. I don't want to go too much into the details, but just again, thinking about the areas that are affected. The top part modulates the circuits, and if there's any pathology there or disruption, then you will get the inhibitory movements that are supposed to be suppressed by, fine-tuned by your cortical networks doesn't happen. And so you get the tics happening. And people have looked at the anatomy of the brain. They found some areas are smaller, decreased basal ganglia, and blood flow has been found from PET studies as well. And just showing that as well. In terms of the neurochemistry, some neurotransmitters have been implicated. So you've got your GABA and your dopaminergic activities have been implicated in the etiology. So what do parents want to know? Parents want to know, why is my child having this? Can this be cured? What's the prognosis and treatment possibilities? Just in your day-to-day clinical work, this is what parents will be asking you. So what do we know about tics? They tend to occur between 5 and 6. They peak at about 10 to 12. The same child may have different tics. And typically you have the motor tics preceding the vocal tics, but we do have few incidents where the vocal tics happen before the motor tics. Tics tend to happen, you tend to see them progressing from top to bottom. So you see eye blinking, face twitching, then the neck, but sometimes you don't have that effect as well. So what we tend to do when we're getting a history, we have to take a good history of the tics. We have the benefit of having eyewitness accounts sometimes and video recording, just like we have in seizures. So just going quickly to comorbidities. So when you're assessing a child for tics, the tics may not be the big issue. The comorbidities are things that you must screen for, because this is what more may be impairing the child more. And I've just put a lot of the comorbidities there. Clinical features. So again, I've just put this there because we see a lot of children who've been seen in allergy clinics for a long time, treated for chronic cough, and what they've had is tics. And they've been given all kinds of medications, whereas the child has had tics. So it's always something, even if we're not neurodevelopmental clinicians, we're seeing children, think about if a symptom has been present for a long time, are you dealing with a child with a tic disorder? Explore the history. You have to differentiate whether it's an acute onset or something that fits into a primary tic, because you can, if it's acutely present, a fever, you have to investigate and rule out any of the post-infectious processes. The comorbidities need to be assessed for, and that's what we're going to be talking about mainly. So when I'm not sure whether we use this scale here. This is one of the main tools that we use in documenting the child's tics and severity, but there are other questionnaires that can be used to screen for tics. I put this here. This is a premonitory urge and tic scale, which is quite useful. It's important because this helps the child to describe how they feel before the tic. Now, one thing that tends to differentiate tics is what we call a premonitory urge. If we think about the fact that if you want to sneeze, so we're all sat in a meeting, if you feel the urge to sneeze, but you don't want to sneeze out, you're holding it, it becomes more uncomfortable. You hold it until a point where you just can't hold it anymore, but you've had that discomfort and then you sneeze. It's the same thing with a child with tic disorders. They have this urge, which can be, it's a sensory urge, it can be local or generalized, but they get a relief after the tic. So if after the vocal tic, they get a relief, after the motor tic, they get a relief. It's always important. Most children with primary tics will get premonitory urges. A lot of children may have increase in tics after school. So the parents may say, when he comes home, he's doing a lot of tics. And that's because the child's probably been trying to suppress the tics at home, at school. But what you have to know is the absence of tics doesn't mean that the child has a good outcome. One of the things I learned during my master's program, we had a lecturer with Tourette syndrome. And when we went into the class, he was very calm and quiet. He wasn't having a tic. And about 5 minutes after, he started ticking. He told us that because he was anxious, he decided to suppress the tics, and that because a child is having lots of tics doesn't mean it is severe. That child may just be relaxed and doing the tics. So I interviewed children 6 to 10 with tics and Tourette's as part of my dissertation, because it was thought that children could not describe urges. And it was very interesting to find that these children could describe urges. They talked about lots of things they felt. So always talk to the children. Don't think they're too small. In their own words, they will describe to you how they feel. Sometimes it bothers them so well, they're fidgeting. People might wrongly diagnose them with ADHD, whereas it's a sensation from the tics. Sometimes they try so hard, they're very anxious, they're distracted by the sensory urges from the tics. Tics can occur at any time. They can, when the child is relaxed or distressed, and you should also think about what in the environment. Is that a very hyperstimulatory environment that is causing the tics? Is the child anxious? And the intensity is also important. Now, if we think about the impairment, we think about several areas in which it can affect the child: home, school, family, and personal. So just coming to comorbidities, I'm going to talk about the important, the more prevalent ones, because we can't go through all the comorbidities. The two most common ones are ADHD and OCD. Always screen the children for ADHD. It can occur in up to 50% of the children. And a lot of the comorbidities, they have shared genes and shared pathology with the TS. So it's very important to screen them. ADHD, it can be the more impairing factor. So when you see a child with ADHD and tic disorders, make sure you treat the ADHD. You might find out that the tics will be improved. And you can manage the ADHD with the different medications. We still give the stimulants. If the tics worsen, we can go to non-stimulants, but still start with the stimulants, except there's a significant contraindication, or if the tics worsen, you can sometimes give a combination. And this is a slide just showing some of the prevalence of the comorbidities that you can get. OCD is very common. And what you do find is some children with OCD, with Tourette's or tic disorders and OCD, tend to get more of the compulsive behaviors of the OCD. So when you see a child having more of the compulsion of the OCD, that's quite common with TS, or as opposed to the ordinary OCD. And it's important to screen as well the children. It can be very impairing in both populations as well. So there are varied reports in ASD. It's not as high, and that's because there aren't such clear studies about ASD and TS, but we do find about 2.9 to 20% prevalence. And this was a study just looking at the different prevalence in different samples. Anxiety is common as well, also screen for anxiety. Learning disabilities are common, sleep problems, rage attacks on its own. This is where the child just has an episodic behavioral outburst, and that's quite common in tics. It's not due to the ADHD, they can get rage attacks. So should all children be treated? No, most children with tics are happy and not bothered by the tics. Most of them do not need active interventions. Reassuring the parents is important. When do you worry? 2 minutes. When do you worry about tics? The time you should be treating the child with tics is if they're having impairment, like injuries. We know some children can have such severe tics that they're hitting themselves. Their neck, having significant neck pain. So that's when we intervene. If you see a child injuring themselves or hitting, bruising, or disruption in learning, or they're being bullied and isolated because of their tics, or it's impacting on their emotional and mental health, think of treating that child. So we also should support the schools with managing the tics. So we should liaise, give information to the schools, because there are things that the schools can do to actually help that child. I'm just going to, so when we think about differentials, always think about differentials. If you're not sure, think about myoclonic movement, think about other tremors, dystonic movements, and seizures. We've had a few patients who've had seizures, epilepsy, and tic disorders. So don't think because it's tics, don't think about any other thing. We've had children where we're managing for both. And this is just a slide showing showing differences between stereotypic motor movements. So stereotypies, motor stereotypies, which I'm not talking about today, can be quite similar to tics, and there are ways in which you can differentiate it. And just to round up, so these are the kind of movements that we've had after the pandemic, and it's been reported in a lot of centers. There was an explosion of this movement. We had, it was thought that TikTok, a lot of children were copying these tics, watching their social media, and completely able to emulate the tics. And we've actually seen some of them that way. So they are like tic-like attacks. We need to be careful. We need to be able to differentiate them from real tics, because we might treat them with medication and it will not be effective. Their function, we have these children having functional tics, you need to be able to differentiate it. And there's a high level of misdiagnosis. The other thing is we don't tend to do MRI scans, except it is relevant or you think that something else is going, but straightforward tics, we don't do MRI scans. So when to conduct investigations, if you think, could there be something organic going on or metabolic, or if this has just suddenly happened and it's not fitting any clear picture, then you should manage, you should think about investigation. So the take-home message is picking up, most children do not need treatment, they need reassurance, psychoeducation, liaising with school. But if there are those worrying factors, then you need to think about treatment. I'm not going to go about this. These are behavioral treatments for tics. Medication, in terms of medications that are useful, we have the alpha-adrenergic medications. What we tend to use a lot, especially if the child has comorbid ADHD, we use Intuniv, guanfacine. That's what we tend to use a lot. If that child has ADHD and tic disorders, that's what we use. We can sometimes use atomoxetine, but if the tic is quite prominent, we use guanfacine. Clonidine was used a lot until we had guanfacine. We use guanfacine because it's more longer active. We tend to stay away from the extrapyramidal medications like the haloperidol because of the effect, but it can still be used. So just to say that there are devices and other treatments being launched or being tried. This is a wearable device that is being looked at for improving managing tics, and it's supposed to help to suppress the tics. And we're looking forward to having this more available, but the clinical trial has been launched. And we do have a few patients going for deep brain stimulation, not most of this in the adult population. We do not really have that evidence for the pediatric population. So the prognosis, the good news is that a lot of children will get better by 18. A third become symptom-free. Half of them might have mild tics needing no treatment. Sometimes a third have persisting symptoms. Weiler found out that the people who tended to persist more sometimes had a lot of comorbidities, and that's why it's important to screen and identify the comorbidities. Future research is needed. So for people, clinicians working in the UAE, I think it's important that we begin to think about how we seeing these children in our clinics, think about the prevalent studies, and developing local materials for them that is relevant to our community for liaising with the schools, supporting the families, because once they understand, then that's better. And that includes things like local videos for them, because that will reduce the anxiety and improve the quality of life for the family. Thank you. Just put some resources there. So, sorry, just to say that a book that was written based on findings from my study was written with a colleague to help children understand ADHD and tics.